Sure.
Okay, cool. Well, thanks for having me to the NERV meeting, which Dr. McCracken told me stands for Nerd Virtual Education, NERVE. I am happy to be captain of that ship and talk about endoscopic ear surgery. I am a Zoom person, not a Teams person, so for some reason I can't see myself. I love to look at myself all the time. So my head might be cut off, or a pigeon may fly through the window and land on my head, which almost did happen the other day. We left the window open. 2 pigeons flew into our main otology room and were there the entire weekend, which shut the room down for several days. Anyway, today we're going to be talking about endoscopic ear surgery. I have actually 3 sort of separate talks I will weave together over about 45 minutes, and then we should have 10 minutes or so for questions at the end. So without further ado, I will launch into it. And if something goes wrong, just someone interrupt and let me know, since I'm not team savvy. Okay, so what is endoscopic ear surgery? So one thing to know is the endoscope is, of course, a tool, not a surgery. You can do a surgery with an endoscope. You can do a surgery without an endoscope. And the question is, what do you do with this tool? Do you just use it to inspect? Do you stick it in the mastoid? Do you stick it in the ear canal? And so when we talk about endoscopic ear surgery, most people sort of are implying that we're doing transcanal endoscopic ear surgery, and we're doing the majority of the operation with the endoscope. I mean, of course, you can use endoscopes for other purposes, but when people talk about endoscopic ear surgery, they're sort of talking about this as the goal of using it exclusively without the microscope and trying to do things through the ear canal that are harder to do with the microscope. So where does the endoscope go? The endoscope is sort of uniquely suited to putting in the ear canal because the endoscope is a long, narrow rod, and the ear canal is sort of a long, narrow structure. It's a natural orifice. Endoscopes are well mated to putting in natural orifices. And the mastoid is very different. It's more like a wide funnel. It's an artificial space. You can make it any size you want. And while there's definitely a role for putting the endoscope in the mastoid, and whenever I have a cholesteatoma case, I actually always use endoscopes through the mastoid to inspect towards the end. It's not really particularly suited for that because you need to drill this wide passageway, and it just makes sense to use the microscope for it. So to help you remember, I have made this very handy memory device. Endoscope is used best in the ear canal. Microscope is used best in the mastoid because the letters align. So you can remember E to E, M to M. So how did I learn endoscopic ear surgery? Well, it's helpful to take a hands-on course if you don't have exposure to it at your own institution. There's a bunch of these. We have one at Columbia, although this year it's still remote because of the remnants of COVID. Hopefully it'll go back to being in person next year. If you have a temporal bone lab and you have some endoscopes there, maybe the rhinologists use, you can play around. We actually didn't have this when I came to Columbia because it was under construction, so I had to learn through graduated practice in the operating room, known as torturing a generation of residents, as I learned to redo surgeries with an endoscope. And I was very slow in the beginning because I had to kind of teach it to myself. So it takes some patience in the beginning. One nice thing about endoscopic ear surgery is that if you record the videos and you don't degrade the resolution, the videos will be the identical quality as what you see in the operating room. And so YouTube is a great resource for those who record and put up high quality videos. And two people who have good quality videos are Brandon Isaacson at UT Southwestern, who's otologic surgery, many more subscribers now, and Nirmal Patel from Australia. So I would encourage learning in a graduated fashion from using the microscope, which is what we all learn and know, to using the endoscope. And so Michael Cohen at Mass Sinus came out with this classification system. I usually don't like classification systems, but I actually found this one to be pretty straightforward. So he basically classifies how much you are doing endoscopic ear surgery from not to actually doing it completely. So class 0 means you do not use the endoscope and you just use the microscope. Then class 1 means you just inspect with the endoscope, but you're really doing everything else with the microscope. You're dissecting with the microscope. Class 2 means you use both tools for both parts. And 2A means you use the endoscope for under half the dissection, and 2B means you use the endoscope for more than half dissection. And then finally, class 3 means you use the endoscope for everything. So I don't know. I find this classification seem sort of helpful as you work your way from being a microscopic to an endoscopic middle ear surgeon. Why do we like the endoscope for middle ear surgery? Well, we feel that the endoscope is very nicely suited to doing things transcanal. Here is a schematic of a microscope looking through an ear canal at the middle ear. And microscopes are great. They're expensive. They give incredible sharp images. You get stereo. But the problem with the microscope is that the widest field of view is defined by the narrowest part of the ear canal. So you get a beautiful but super narrow view. Whereas the endoscope, you can stick the tip, the optic, past the constriction of the ear canal. You can stick it very close to the source, and you get a beautiful, really wide field of view, which is very nice. So the microscope, by analogy, is kind of like looking through a straw, whereas the endoscope is giving you a very wide field of view. So the haters will counter and say that, or the endoscope is 2D and the microscope is 3D, and that's true. And then I'll say the microscope is like looking through two straws. Would you rather see beautiful wide field with one eye, or walk around looking through two straws? So the view is much wider. Here is a view of a perforation through a microscope with a speculum. So the gray stuff is a speculum. And then here's the same perforation with the endoscope, and the white circle denotes the microscopic view mapped onto the endoscopic view. And you could just see the endoscopic view is wider. With the endoscope, you also see the annulus in green and even a lot of the ear canal in the blue color. So here's a head-to-head comparison of the endoscope versus the microscope. What we just discussed, field of view, advantage endoscope, it's much wider than the microscope. Now 3D, clearly an advantage with the microscope. 3D is great if you can get 3D. You'd want to use it. They do make 3D endoscopes, but they're quite large. They're not as small as the endoscopes we use in the middle ear. They're just not quite there yet, but maybe one day they will be. Two-handed surgery, clearly advantage microscope. Although I put a little asterisk because this may be changing, as I'll talk about with a new tool. Curetting, advantage endoscope. You don't need to curette as much because you can use angled optics to see around corners. Typically, you curette to see stuff that's blocked by bone. With the endoscope, you only curette to be able to touch stuff that you can't touch because the instrument is contacting the bone of the ear canal. So you don't need to curette as much to get that. The ability to do stuff transcanal. All things equal, if you could do the same surgery transcanal postauricular, patients would appreciate it if you could do it transcanal. There's a smaller incision. There's no pain or numbness behind the ear. So with the endoscope, by definition, we're doing things transcanal, whereas with the microscope, a lot of cases that you operate on the middle ear just can't be done transcanal for a variety of reasons. Price comparison, endoscopes generally are cheaper than microscopes because you already have them for sinus surgery. They're already laying around, although you may want to get a slightly narrower endoscope for ear surgery. Whereas buying a microscope is expensive. I mean, in big academic centers, we typically have both, so it's less of an issue. Advantage in terms of learning, clearly advantage microscope because you will learn it automatically in your training, whereas with the endoscope, you may have to learn it on your own or by going to courses. Team view, I don't think this should be underestimated. The team view is amazing with the endoscope because the whole team seems the same great view as the surgeon, whereas with microscopic ear surgery, the surgeon sees really well, and then everyone else in the room has a sort of crappy view from the side port that sometimes is okay. Oftentimes it's totally off the screen. I mean, I can't even count how many times I'm doing a surgery and there's like a med student in the room, and I look at the screen just to see what the med school student is seeing, and it's like completely not where I'm operating, and it's been like that for an hour. And then fun. While all ear surgery is fun, I think the endoscope is funner, partly because everyone can see the same view. Everyone's head is up. The music is a little louder. Everyone's on the same page. I just think it's great. So to conclude my intro talk here, I'm just going to give some sort of random select tips on what is helpful to start out doing endoscopic ear surgery. And then after, we will launch into another much more dry lecture on anatomy. So if you have a cup of coffee, I would start drinking it quickly because we're about to talk about anatomy for 20 minutes. But first, select tips. So I really like this tool, the suction round knife. This is one of my favorite tools. This is the so-called Lee suction round knife built by Dan Lee and Mass Eye and Ear. And as you may have guessed, it marries a round knife with a suction, and this allows you to elevate the tympanomeatal flap with one hand while the other hand is holding the endoscope. And this is incredibly helpful because raising the flap is often the most challenging and bloodiest part of the case. And it's also the first part of the case, and so it causes a lot of people to abandon endoscopic ear surgery. But this tool makes it a lot easier. Curved suctions are also incredible. I think this is also a Dan Lee special. This is one of a variety of curved suctions. They're helpful because with the endoscope, you can often see around corners. And in order to operate around corners, you have to have curved instruments. What we typically don't use in endoscopic ear surgery is a scope holder. A lot of people, the first thing they think is, oh, you need a scope holder so you can operate with two hands. That doesn't work for a variety of reasons. Number one, there's just not enough room for a scope and your two hands. The ear canal is just not wide enough unless everything becomes narrower. All instruments become narrower. You just can't get all that stuff in there. Or unless you do some kind of giant canalplasty, which makes it longer and more recovery with the ear canal skin healing, and then why don't you just go postericulator? There's also advantages to holding the scope in your hand because you can constantly change the angulation, and it gives you what we call pseudo 3D. We also don't typically use an irrigating, or I should say we've never used an irrigating sheath on a scope because it would make the scope fatter and it just doesn't really work. So instead we use this Fred. What do you do in narrow ear canals? Those cases make it a lot harder. I would just not do any narrow ear canals when you're starting out. Do all those microscopic postauricular. You have to have more patience. You can use a narrower endoscope. You can also take some time and do a canalplasty, particularly if it's a canal that just has like an anterior bulge in a focal area. If you can drill that away, that will help. Canalplasties can take some time. It takes some time to drill under the endoscope because it creates a lot of bone dust. And unless you have someone holding a suction in there and knows some special tips and tricks, it just soils your endoscope tip and you wind up drilling for a second and then wiping the scope and drilling for a second and wiping the scope. And you can always abandon and just do postauricular. So learning should be stepwise. As I mentioned, taking a course is helpful in the beginning. I don't remember why I put the bullet fellowship here. Maybe this was during our fellowship interviews or something. But in any case, then you want to start simple, do easy things that you absolutely do not need an endoscope to do, like tubes. What is the advantage of doing a tube with an endoscope? Zero, but you can practice. Then things like a laryngoplasty, and then you can use it as an adjunct to take looks during microscopic transcanal tympanoplasty. Then you can practice raising the tympanomeatal flap. Then you can do an actual tympanoplasty with the endoscope. And then at the very end, you can add pathology like cholesteatoma or exotic pathology like glomus tumors, or if you're really a cow person, as we say in New York, exotic pathology like vestibular schwannomas, which I don't do transcanal. That's it for talk 1 of 3. We are actually having a special course this Friday. If you go to columbiaendocourse.com, you can sign up. It's going to be Friday morning, 8 to 11:30, and it's free for everyone if you want to play hooky from your residency and get fired. So let me start my second talk here. All right, let me do the share tray. Okay, I think this is working, getting the hang of it. Can someone just, I can't see people's videos. Good. Okay, thank you. Sharing is paused. Okay, now it's working. Oh, sorry, can you give me like 20 minutes? I'm just on a Zoom, thanks. So, all right, let's talk about endoscopic ear anatomy. So here's an overview of this talk. We're going to do some background and then go by anatomy by compartment. I love giving this talk because you can see anatomy really well with the endoscope, better than you can with the microscope because you can see all the compartments of the middle ear. This is a little bit more of an anatomy talk than an endoscopic talk, but it's a great way to show you the anatomy. So I will torture you. So some people may think that learning about anatomy is like watching paint dry, but grab a beverage of choice and maybe this will be more interesting. So all images in this talk are going to be oriented like this. It's all going to be a right ear. Superior is going to be to your left. Inferior is going to be to your right. Posterior is going to be to the back. Anterior is going to be to the front. Let me get my laser pointer. I know this works on Zoom. Can people see a green laser pointer? Hopefully. Yeah. Okay, cool. All right. Nice. This is working. So yes, let's jump in. So I already showed this slide. The point is the endoscope lets you see a wide field of view, and you can see much wider, as I talked about. So why is this relevant? Because much of the middle ear is not in line of sight. So the black circle is the annulus. So if you like resected the eardrum and didn't have any bony obstruction with the microscope, the best you could see is the black circle. But there's a lot more stuff in the middle ear that's not directly in front of the annulus, and you can really only see that with an angled endoscope or like a massive amount of curetting. So it's easier to see this with the endoscope. So I'm going to go through anatomy by compartment, and I'm going to use this schematic here of a circle inside a square with a bunch of lines. So the middle ear can be divided into 5 compartments. I think the seniors probably know this, maybe the juniors don't. These words are a little frightening in the beginning, but they're actually very simple. So the word mesotympanum, that merely means what is directly deep to the eardrum. So if it's under the eardrum, that is the mesotympanum. And then depending on whether the compartment is above, in front, below, or in back of the annulus of the eardrum, we have these other compartments. The epitympanum is superior, the protympanum is anterior, the hypotympanum is inferior, and the retrotympanum is posterior. So I'm just going to walk through these 5 compartments and point out some cool anatomy. So we'll begin with the mesotympanum. So this is a Jackler-Graham or a Graylap-Graham. I assume everyone knows about this. If you Google Jackler-Graylap, they have these amazing watercolors of the middle ear and skull base that are free and online, and it's like the netter of the middle ear. It's free on purpose on the Stanford Department website. So I've used these for this talk, some of them. So this is a schematic of the eardrum. The black circle is the annulus. So what we're talking about, the mesotympanum, is what's directly below the eardrum. So you can see the malleus, which is here, part of the malleus, part of the incus, part of the stapes. So now we will flip up the eardrum, and this is what we see. If you're doing a tympanoplasty, this is the first thing you see when you, quote, lift the flap. You see the IS joint. That's like the first thing you see with the endoscope. You immediately see the IS joint. You never have to curette to see the IS joint. You see it really well. Incus, stapes. IS joint is the joint, I guess I should say for juniors. It's the joint between incus and stapes. IS joint. And then you have the stapedius tendon that connects to the neck of the stapes. And then up anteriorly here is the malleus, the manubrium or handle of the malleus. That's always attached to the eardrum. The eardrum is like very densely adherent to the malleus. You can't lift the eardrum any further forward unless you cut the eardrum off the malleus. We can also see here the promontory, which is basically the inner ear, the cochlea, and the basal turn. The round window where we stick cochlear implants is in this little cave here. And then looking superiorly through what's called the isthmus, you can see into the epitympanum. So now in this study, fortunately, the patient has died. So they were alive here. Now they're dead. So there's no more blood, but that's OK. We can see anatomy much better. We've cut the eardrum off the manubrium, and we can now see a little more anterior. We can see the tensor tympani attaching to the neck of the malleus. We can see, again, the incus and the stapes. Here, this looks more like a stapes. We can see the anterior crus, the head of the stapes, the posterior crus, the stapedius tendon. And we can also see our friend the facial nerve, which is always directly superior to the stapes, this fat pink structure. And if we remove the incus, which we often do in middle ear surgery when it is eroded and not attached to the incus, the stapes, we can see a lot more. So now the incus is removed and we've done a little curetting, and we can see the facial nerve in great detail. We see the stapes in great detail. This doesn't look like, stapes and netter because you are like a bird flying over the top of the stapes, so you don't see the crura, but you do see the head, I guess part of the anterior crus and posterior crus. Here's the stapedius tendon. The pyramidal eminence is the triangle that the stapedius tendon comes out of. And now we will move on to the next compartment, the epitympanum. So now we're going to be looking superiorly. So we can still see the stapes here. This is the anterior crus, posterior crus Here's the head of the stapes here. Here's the stapedius tendon attaching to the neck of the stapes. Here's the incus, part of the incus anyway, and the incus stapes joint, it kind of looks like it's cut here, like there's a little space between the incus and stapes. And we can see the tensor tympani here, and we can start to see some structures of the epitympanum. What's incredible about the endoscope is mastoid structures sort of become middle ear structures because you can see so far superiorly and posteriorly. This is a horizontal canal, which you can see right superior to the facial nerve. If we cut the TM off the malleus, we can see some more good stuff. We can see what we call a Prusak space. This is an important term. Prusak space is basically the space between the ossicles and the scutum. What is the scutum? It's the bone that's just lateral to this. And Prusak space is relevant because this is the place where cholesteatoma typically starts. So you'll see that a lot in radiology reports. They'll say that there's soft tissue Prusak space, and then they'll say with or without scutum erosion. If the scutum's eroded, that basically means there's cholesteatoma. So just to review here, here's the malleus handle, here's the incus, and this structure right here is the chordotympani nerve, which goes over the incus and under the malleus. The malleus and incus are like a number 11. They're these two parallel lines. So if you see one, you can see the other. So if we do a little more curetting and then remove the incus, we can see some more fun stuff. We can see the entire malleus. Here's the head of the malleus, the neck of the malleus, the manubrium. The incus is gone, of course. Here's our friend the stapes, and then just superior to the stapes is the facial nerve, and just superior to the facial nerve is the horizontal canal. So these three structures are always in a line. Stapes, facial nerve, lateral canal. If you find one, you can find the other too. And then here's our chordotympani nerve going deep to the malleus. And if we look backwards here, we would see into the mastoid. This is again looking superiorly. We see we've removed the malleus here. We can see the cochleariform process, from which comes the tensor tympani connecting to the malleus. Here's the facial nerve, the stapes, and the horizontal canal. So again, three parallel structures: stapes, facial nerve, horizontal canal. Stapes, facial nerve, horizontal canal. They're like three parallel lines. Oh, and I will illustrate for you. Lateral canal, facial nerve, stapes, three parallel lines. Okay, let's move on to the retrotympanum. This is the most esoteric of the compartments because you don't often see these structures with a microscope unless you do massive bone removal or a canal wall down. So this is going to be a schematic of these, quote, hidden structures of the retrotympanum going from superior to inferior. And the keystone structure is the round window overhang. So I'll show you this in the next couple slides, but the round window lives in a little niche, and the bone that covers this niche or space is the overhang. And from superior to inferior, we have a bunch of ridges. So let me just say this again. So this is like anatomically oriented. So round window overhang is here. So just posterior to this, we see three parallel structures. We see something called the ponticulus, something called the subiculum, and something called the funiculus. The subiculum comes out of the superior part of the round window overhang. The funiculus comes out of the inferior part of the round window overhang. And then the ponticulus is superior to this. Just as a disclaimer, okay, this is getting very esoteric. You don't even normally see these structures. In fact, the only reason why I'm including these is so that if you memorize it, you can just impress the hell out of your attendings because they may not even know which structures these are. So between the ponticulus, not the attendings on this teams, but other attendings. Between the ponticulus and the subiculum is a cavity called the sinus tympani, and between the subiculum and the funiculus is this cavity called the subtympanic sinus. Okay, I'm done introducing new terms. I will now just show you these terms on the next couple slides, and then we will quickly move on to the next space. All right. So again, ridges, ponticulus, subiculum, funiculus, spaces, sinus tympani, subtympanic sinus, and this is all posterior to the round window overhang. Next slide. Here's our keystone structure, the round window overhang. And going from superior to inferior, here are those three ridges. Number one is the ponticulus, number two is the subiculum, number three is the so-called funiculus. And then between those ridges are two cavities. Cavity one is the sinus tympani, cavity two is the subtympanic sinus. Now I'm just going to keep showing you this to torture you a little bit at 5:30 on a Monday. So Here's ridge 1, the ponticulus. Here's ridge 2, the subiculum. And between the two is what? It's the higher cavity, the sinus tympani. If we look a little more posterior, we can see the ponticulus again and the subiculum. Sorry, I should try to orient you a little, just to back up. Here's the round window overhang, and here's the stapes. Okay, so the round window overhang is here, and I mentioned that coming out of the superior part of the round window overhang is this subiculum. And then just superior to that, there's this little ridge called the ponticulus. And between the two is this little cavity called the sinus tympani. Okay, I'm going to now move on. Hopefully you absorbed a tiny bit of that. So let's talk about the hypotympanum, which is much easier. There's not much in the hypotympanum. There's really just a couple things, or I guess, yeah, just a couple things. One key thing is the jugular bulb, which is shown in the blue box here. If you look kind of closely, it has a little bluish tinge, and sometimes the jugular bulb can be more superior, sometimes it can be more lateral. You just don't want to stick a rosin through the jugular bulb, because if you do, there will be bleeding. I've only gotten into the jugular bulb 3 times in my career, twice of which have been with Josh Sturm, who's on the call. I think both times I said, like, push right there, and then he did exactly what I said, and then there was bleeding. And then if that happens, you just put some pledgets, and it's a low pressure system. It always stops. It stopped in both cases, and we're able to continue the case. And then when we went back and looked at CAT scan again, we said, oh, we probably shouldn't have done that. And the patient was fine and had perfect hearing. So let's move on to the protympanum. This is the space that's anterior to the annulus. And like the hypotympanum, there's not much in there. One key structure to know about is the eustachian tube. So here's the eustachian tube, unmistakable. It's a gigantic hole in the anterior part of the middle ear. Here it is. And the tensor tympani muscle kind of goes into it a little, and so does the carotid artery. So notice here's the eustachian tube, the hole. The tensor tympani muscle and the carotid are like right at the opening. So just some overview slides of the entire anatomy, and then we'll move on to the third part of my talk, which is the most fun part, the future of endoscopic ear surgery, and then we'll take questions. So here's a view of a lot of the middle ear. The eardrum has been removed. This is kind of intended to be a review, so I'm just going to walk you through all of the interesting bits of anatomy in the middle ear. So right smack in front of you, you see this smooth dome-like thing. This is the promontory. The promontory is basically the cochlea. And what part of the cochlea? It's the basal turn. It's the part that does treble. It's the part that you encounter first when you stick a cochlear implant electrode in. You would stick a cochlear implant electrode through the round window. This is the round window niche, which is covered by adhesions, as it often is. So you don't actually see the niche, and you certainly don't see the membrane or the window because there are adhesions covering it. Over here is the malleus, the manubrium of the malleus. There's no eardrum, of course. If there were, it would be attached to the malleus, and you wouldn't see anything anterior unless you cut the eardrum off the malleus. And then the inferior tip is the umbo. Going posteriorly, here's the incus. So recall the malleus and the incus are like 2 parallel structures, like a number 11. And then as we follow the incus inferiorly, we encounter the stapes head. That junction is called the incus stapes joint, or ISJ. We don't really see any more of the stapes, because if you try to see the stapes upon first entering the middle ear, you're like a bird looking down on the stapes, and you won't see the arch shape unless you look from inferior. You have to kind of tilt your view sideways and look up at it to see the horseshoe. So we don't see the horseshoe at all. However, we do see the stapedius tendon. So just superior to the stapes is our friend, the facial nerve. And then just superior to the facial nerve is the horizontal canal, which is probably right here. We don't really see it well, but this smooth bone might be the horizontal canal. So here's another relationship of parallel lines. Stapes, facial nerve, horizontal canal. Okay, so the parallel structures are malleus and incus. Those are parallel structures, malleus and incus. And then in the other 90-degree orientation, it's stapes, facial nerve, horizontal canal, which you don't really see. If we look if we look anteriorly, we can see the carotid, this red structure here. If we had an angled endoscope and looked more anterior, we would see the eustachian tube. This is basically where it is. We're just not looking down it. Just superior to this is the tensor tympani muscle, which would go into the tensor tympani, which we don't see because it's deep to the malleus here. And then looking inferiorly, here are some air cells. This looks like what you would encounter in the mastoid. Inferiorly are these air cells. We call them hypotympanic air cells. And I think we pointed out all the good stuff. So let's go on to this next slide. Now we've taken out the malleus and incus. So I'm going to go through all the anatomy again, just without the malleus and incus, so you can see more stuff. So let's start with the promontory, which is right dead center. This is the out kind of pouching, not outpouching. This protuberant bone. It's like a little shell almost coming towards you. It's the basal turn of the cochlea. And then the round window is right here. That's opening number 1 to the cochlea. Opening number 2, of course, is the oval window, which is what the stapes footplate is on. You don't really see the oval window unless you remove the stapes. So promontory is right here. And then let's focus our attention on the stapes. Here's the stapes and the stapedius tendon coming out of the pyramidal eminence. If you recall, I said that there are 3 parallel lines, the stapes, facial nerve, and horizontal canal. If you find one, you could find the other. Again, stapes, facial nerve, horizontal canal. Then HC, this is a hypotympanic air cell. So the point of this is to tell you that when you do a cochlear implant, if you don't know where you are, you could think this is the round window and stick it in it. Like if you just are trying to do a cochlear implant, of course, cochlear implants we're doing transmastoid through facial recess. The view isn't exactly like this, but if you just see a hole in the middle ear, don't just stick it in the hole, assuming that's where it would go. If you're too inferior, it'll go into an air cell, and that's not where you want to be. Here is the, I think this is supposed to be the jugular bulb down here, although it has kind of like a reddish, oh wait, hold on. So actually, I think this is the carotid. Yeah, I think this is the eustachian tube, and this must be the carotid right next to it. All right, that concludes our anatomy talk. Hello? Someone's mic just turned on.
You are correct, sir. Big red.
Yes. You can stick a pick into the jugular bulb and it will be bad but not lethal. Do not stick a pick into the carotid artery. This view is a little rotated. Typically, this eustachian tube orifice would be kind of here, which is an important point when you're using the endoscope. If the endoscope is rotated, that could confuse you like it just confused me. One way you can notice this is confusing is because the facial nerve should be going up, down like this, but it's not. It's actually 45 degrees, which is why I got confused and was trying to tell you this is the jugular bulb, but it's not. It's the carotid, because normally the carotid would be here. All right, here's a shameless plug for our course this Friday. It's actually a 3-day course. It's Wednesday, Thursday, and Friday morning by Zoom. You can register for free going to this website. Day number 1 is sinus, day number 2 is orbit, and then day number 3 is endoscopic ear. So for my final talk, I'm going to talk a little bit about the future just in 5-10 minutes. Then we will take questions. Okay, can people see my new and future PowerPoint full screen?
Looks good.
All right, so the question is, what do we need to take endoscopic ear surgery to the next level and have it be more broadly adopted? It is very much a niche field, and part of the reason it's a niche field is that it's very hard to learn. And you can do, if you're a microscopic ear surgeon and you're getting great results with your microscopic approach, why would you ever switch if it's going to be super hard? Because, you know, all you're doing is a slightly larger incision, but you're achieving the great meaningful results of improved hearing and disease control. So why would you switch if it's difficult? And that's a great question. You wouldn't, and that's why more people aren't switching. So if we want endoscopic ear surgery to really take off, it's got to just be easier to do. And it's not going to get easier until we have better instruments that are really designed for endoscopic ear surgery. And the analogy is with sinus surgery. When people started doing endoscopic sinus surgery, for a time it was a little bit of a niche because the instruments were terrible. But as more and more specialized instruments came out designed for FES, I mean, it really took off. And now, like most instruments are sort of FES, designed for FES or appropriate for FES. So we need better instruments. We also need suctions in instruments, in more instruments, because you typically are holding the endoscope with one hand. So you're giving up the suction in your non-dominant hand. So the third thing that we need are better endoscopes, endoscopes that are designed for endoscopic ear surgery and better quality imaging. And there actually are some EES specific endoscopes being developed, including one that exists that I will tell you about. So bleeding is truly the enemy of transcanal endoscopic ear surgery. It just makes everything terrible because you usually don't have a suction in your hand unless you are only suctioning and doing nothing else. When you are dissecting, you don't have a suction in your hand. So if there's bleeding during dissecting, you're kind of screwed unless you have a special suction dissector. So what else can you do if you don't have a suction dissector? You can use epipledgets, which are a great technique. You can certainly use this with the microscope as well. It's a lot of endoscopic ear surgeons are more into pledgets because they're more necessary. But these 1 to 1,000 epipledgets are great because they will dam up the bleeding while you operate. So this slide here is showing you entering the middle ear, and there's often a lot of blood pooling as you're trying to enter the middle ear. So you could put a pledget next to the annulus, and it will be like a sink for the blood as you get into the middle ear. Once you get into the middle ear, then the blood will go into the middle ear, and suddenly the bleeding is not as disturbing. You can also just wait. If it's bleeding, you can put a pledget and wait. Waiting is extremely difficult for surgeons. One thing you can do is get your cartilage graft while you're waiting for oozing to slow down. The problem with bleeding is you often are in this pattern of using a suction and then dissecting, and then there's more bleeding, so use your suction, then dissect, and you're switching a lot between suction, dissecting, suction, and dissecting. So I'm very much a proponent of using suctions a lot. I actually do a lot of dissection with curved suctions. It's just like a blunt Rosen needle. It's great. You can even elevate the annulus with this curved suction. I also love this suction round knife, which is designed for endoscopic ear surgery. It's this line of tools called EndoEar, which is available through Grace. But I think we need more instruments. What kind of instruments? I don't know. I'm not an inventor. Someone on this Zoom on this Teams can invent it, and then I will buy it from you if you make it and it's helpful. What would also be nice are lighter endoscopes and more ergonomic endoscopes. It would be nice to be able to use two hands. It would also be nice to have better resolution, or maybe 3D back, or maybe VR. I don't know, the metaverse is this thing. Maybe we could be operating in the metaverse and just be seeing that. We could be like, you know, just put on goggles and suddenly we feel like we're in the middle ear. I don't know how we would do that, but if one of you invents it, I will use it. I want to just briefly talk about this cool novel endoscope that I really like. I don't have any like equity in this company. They don't pay me to consult. I just like their product. It's this thing called the Colibri. It's made by this startup Israeli company called 3NT, and it's designed for endoscopic ear surgery, which is pretty cool. The endoscopes that we currently use, the Stores style endoscopes that are 3 millimeters wide, 14 centimeters long, those are not designed for endoscopic ear surgery. They're used by many kinds of surgery. They just are about the size that's convenient for using in the ear. And I mean, just think about using a typical endoscope. You hold the camera in your hand like it's like a small brick. You're using your like fist to hold it. Does the word fist seem appropriate when you're doing delicate ear microsurgery? Like, why would your hand ever be held in a fist? You're doing that only because there's no other alternative. With this endoscope, oh yeah, here's me illustrating that. So standard endoscope, you're holding the endoscope like a fist, but with this Colibri thing, you hold it like you hold a regular instrument. It's very ergonomic. It's light. You can brace the hand. Your pinky is on the patient's neck or face versus your fist just being in the air. But the coolest thing about this is that it has a built-in suction. So it gives you your thumb back to suction. So I like saying it's like having operating with 1 1/2 hands instead of one hand. The suction, I think I have it in a future slide. I'll show you more detail, but it's this curved suction. And by moving this thumb plate 360 around, you can manipulate the curve of the suction. So you actually have some ability to maneuver. Here is a terrible screen capture of us using this Colibri device. In the left hand is the suction of the Colibri. So this suction is coming out of the endoscope shaft. The suction is inline and parallel to the endoscope shaft. And then in the right hand, I'm using a Rosen. And so it's helpful here to position this porp. So here's me using it. You can't tell, but I'm smiling because it's nice to use. The endoscope is directly in front of me. This is their first generation screen, which is incredibly small. Now they have a normal sized screen. And it's just very ergonomic. You could see my pinky and ring finger are on the patient here, so I'm not like shaking at all. The endoscope is extremely steady. Why have a suction in your second hand? Well, you can suction bleeding, which happens all the time with surgery. Not my surgery, but every other surgeon is bleeding and they need to suction it, so the Colibri is helpful. Another killer feature of having a suction in your left hand is tension countertension. When you're cutting something, you want to kind of like pull it tight so you can cut it. You can readily do this when you're doing microscopic ear surgery. It's very hard to do this with the endoscope, but it's frustrating. You're trying to cut something floppy, you just can't cut it because you need your second hand to make it tight, but you can do this with the Colibri suction. Another killer feature is aspirating bone dust when you're drilling or doing a canalplasty. It's torture doing canalplasty, and the bone dust in 1 second obliterates your view because it gets on the tip of the endoscope. With this device, you can put the suction tip near the drill, and then it gives you more time to drill. And then, as I just illustrated in that picture, you can get two-handed prosthesis placement. I think this is a video. Oh yeah, so this is a video here of, I think this is Dan Chu's fellow in Cincinnati Children's doing a canalplasty, and see they're drilling here with their right hand, and in their left hand is the suction, and the suction is instantly aspirating the bone dust so that the field didn't get obliterated within a second by bone dust getting on the tip of the instrument. Here is another video of elevating the tympanomeatal flap. So this, I think the company gave me this video, which is why it looks so sharp. So here in the surgeon's right hand, they're using what appears to be some kind of round knife. This might be like a modified flap knife, or, oh no, this is maybe a beaver. Some kind of nice round knife that I don't have. Oh, I guess this is the beaver round knife. In any case, the point is that with the other hand, blood can be immediately suctioned away. Then something else that would be nice is better image quality. Just to kind of give people some literacy when they talk about resolution. Resolution refers to the number of pixels in a digital image. It doesn't have to do with sharpness. If an image is sharper, you're effectively getting more resolution. But typically when we talk about digital resolution, we're purely talking about number of pixels. Okay, so when you see a digital image, it's like thousands of little dots that are red, green, or blue. Okay, so SD is standard definition, and that means that there's 720 pixels in the horizontal and 480 pixels in the vertical. So if you multiply these two numbers, it'll tell you how many pixels there are. HD means you have double the horizontal pixels and double the vertical pixels, and when you double two numbers and multiply them, you get like many times more resolution. I can't do math right now, but I think that should be 4 times. And then what 4K means is you've doubled again the number of pixels horizontal and vertical, so you get 4 times the resolution. So 4K means, it's kind of a stupid term, it means the number of pixels you have in the horizontal orientation. So it's really 3840 that they round up and call it 4K. Whereas HD, you may recall, used to be called 1080p. 1080 refers to the number of vertical pixels. I'm convinced this must be companies just kind of trying to confuse us. So HD is named after the number of vertical pixels. 4K is named after the horizontal pixels. It's so damn confusing. That's why I wanted just to illustrate this slide. So currently endoscopes are about HD, and they do now have 4K endoscope cameras, including these two nice products made by Stryker in stores. It's supposed to have 4 times the resolution of HD, but it doesn't really. It feels like twice the quality because I think we become limited by the sharpness of the optic. We're using very narrow, tiny endoscopes for middle ear surgery. So I think the rate limiter becomes the optics rather than the digital camera for what we do. Here is a video of a 3D endoscope. These are amazing, but they're not really narrow enough to use readily in the middle ear. They also are sort of problematic. I've used them in cadavers. If you get a little blood on one, then suddenly the color becomes really off and the 3D becomes off and it gets confusing. So yeah, we just need more product development for these. And that is the abrupt ending of all my talks. So if anyone is still there and awake, I'm happy to take questions for the next 10 minutes or so.
That was
Thank
awesome,
you.
Golub. Thank you. Really, really nice pictures. And we always, well, I don't want to say we always, but I think middle ear anatomy is really tough because of like what you said. Often as residents, we're not seeing it from the endoscopic viewpoint, from the mastoid side and then the canal side, and having to like create a map for ourselves from those two views. So those are really nice.
Thanks.
I have some questions. I mean, I want to allow everyone else a chance to ask, but maybe this will get the discussion going a little bit. You mentioned at the beginning of the talk that you always use the endoscope in a mastoid case at some point. It sounded like
for a cholesteatoma. Yeah, not a cochlear implant, but yeah, go ahead.
Yeah, for cholesteatoma. Just curious, in your experience, how often have you found residual cholesteatoma when you're using the endoscope? Do you think it's changed your exposure? For example, do you now go smaller, if you will, or go less into the epitympanum because you're able to pick up more things? So kind of a two-parted question.
Yeah, that's a great question. So I began using the endoscope the moment I wasn't attending. So I mean, I did cholesteatoma surgery with the microscope as a fellow, but I did my fellowship at Cincinnati, and they do the like Iowa canal reconstruction technique. So I never really did cholesteatoma surgery in the conventional way, except as a resident briefly. So it's hard to really compare it to my experience with the microscope because I never really did it in the usual way with the microscope. I like immediately embraced the endoscope. But I really feel it's a helpful tool for inspecting. So if you take away nothing from this talk, or if my talk convinced you that the endoscope is the stupidest thing ever and you don't want to use it for transcanal surgery, at least I will say, take out the endoscope when you're doing cholesteatoma surgery, because it doesn't really take much extra work to use an angled endoscope to look around, because you could definitely find residual disease. In terms of whether like I find residual disease or not, that's hard to say because it's not like I use the microscope and I'm like, aha, I'm done. Now let me see if I left any. Let me take out the endoscope. It's not like that. I'm like using the endoscope all the time. And like as soon as I see the horizontal canal, I'll like open it up and then I like immediately take out the endoscope and just look for the cholesteatoma I know is there. I'm not struggling to see it with the microscope. I just like open up this big port with the microscope and then I start sticking in my endoscopes. That's my strategy anyway.
Okay, that makes sense. Are you using the endoscope for transcanal cholesteatoma removals, or are you, if you know that there's cholesteatoma, scutal erosion, thinking about a mastoid, are you just going to go straight to combined kind of transcanal, transmastoid?
Yeah, great question. I'll preface the answer by saying on the spectrum of people who are microscope zealots to endoscope zealots, I'm definitely plastered to the right. I'm kind of an endoscope zealot, and part of that reason is this is like my academic thing. Like I pride myself on trying to push the envelope and see what can be done with the endoscope. Like I will spend an extra hour in a case using the endoscope when there's no good reason to do that. I'm only doing it because I just want to see if it can be done. That's like why I'm in academics, because I like to experiment. So I don't necessarily do things the most efficient way, but in any case, to answer your question, I never do middle ear surgery with the microscope. Like anything in the middle ear, I will use the endoscope. So that's just my point of view. I just feel like it's at this point it's easier for me to do middle ear surgery with the endoscope because it's all I do. I'm a terrible microscopic middle ear surgeon. I do stapes with the endoscope middle ear because I am just a better endoscopic middle ear stapes surgeon than microscopic, because my microscopic middle ear surgery skills have atrophied. So I routinely do middle ear cholesteatoma surgeries with the endoscope all the time. I lift the flap, I see the cholesteatoma, and then if it's traveling into the mastoid, then I will put down the endoscope and do the mastoid with the microscope. You can't really do a mastoid with an endoscope. That just doesn't make any sense.
I've read that the posterior extent of cholesteatoma involvement that makes use of endoscope reasonable is at the level of the horizontal canal. Do you agree, or do you follow that, or is it kind of a loose?
Yeah, great question. Yeah, with a 30 or 45 degree endoscope and a judicious or modest amount of curetting of the scutum, you can see the horizontal canal, and if there's cholesteatoma tracking to the edge of your view, that's the point where I will just give up and do a mastoid. I mean, if you're really nuts, I guess you could just keep curetting and try to like get into the mastoid through the middle ear, but from my experience, it becomes like painful. It's very hard to see, and I kind of like lose confidence. I really am seeing completely into the mastoid. Like maybe there's little bits and pieces, and then you just do the mastoid, in my opinion. So what you said is correct.
Thanks. Anybody else with questions? I'm out.
Josh, if you would like to point out cons of endoscopes from working with me, you can feel free to do so at this point. I'm just kidding. Or pros, or cons.
I don't have any specific cons. I mean, I really enjoy using it. I think the only con I can think of is sometimes it adds time if we spend a lot of time trying to achieve with the endoscope and then we have to convert to the microscope. But that also goes along the lines of what you're saying of trying to push the envelope about what's possible with using the technique. So it's a lot of fun to use it. I've really enjoyed learning how to do it.
I do think it's very good for teaching. That's one thing I am like 100% convinced of, is that I really feel it's easier to teach trainees with the endoscope, because when they're operating, I can like walk up to the screen and I can take my index finger and say, touch that, and point to the screen, and they can't, there's no ambiguity of what I'm talking about. Whereas when you're teaching a resident and you're with the microscope and you're on the side port, you have to like take a pick and like stick it in the field to explain. It's just, you're all looking at the same thing. It's much easier to teach when you're all looking at the same thing. You're not like really looking at the same thing with the microscope. I mean, I guess you are, but you can't stick your finger and point.
I guess since the residents are spending a lot of time doing endoscopic sinus surgery relatively early on in training, also it's easier, I think, for some people to transition to learning middle ear surgery with the endoscope because they're used to holding an endoscope in the left hand and doing things with their right hand than if they haven't used the microscope that much. I guess it all just depends upon it in a given residency what skills they're learning first.
Any other questions? I guess in the last minute or two, oh, was there a question? I heard a mic pop on. Okay, so in the last minute, I just want to say what I think the true pros and cons are. So I want to make it very clear. I don't think that endoscopes are like good and microscopes are bad. I use both tools. In the right hands, both can achieve the same outcomes. I really don't think there's convincing evidence that a master endoscopic ear surgeon gets better results than a master microscopic ear surgeon. I think they get the same results. I think we can say the endoscope has achieved parity with the microscope for results in terms of cholesteatoma disease recurrence and hearing outcomes. It's just with the endoscope, you can often do it without making an incision behind the ear. So you're saving the posterior incision. I think that's the clear advantage. And is it the worst thing in the world? No, but you know, if whenever I explain to patients we can go posterior or we can go transcanal, you know, they're always going to opt for the quote less invasive technique. So from like a marketing practice building standpoint, as a junior attending, if you're safe with the endoscope, there's like marketability to doing that. I also just like, I don't know, I really enjoy it. I think it's fun, and I think it's really great for teaching. I don't know, I really enjoy looking at the screen. It just feels like you're part of the team when you're using the endoscope, and with the microscope, you're kind of in your own little world, which is cool. When I do my CIs and I'm drilling, or skull base and I'm drilling and I'm in my own little world, there's a role for that too. Maybe that's part of what draws us to otology.
Awesome. Thanks so much, Dr. Golub. Great talk. It was a pleasure to have you. I think we'll call it now.
All right. Thanks. It was an honor. Dr. Meyer, thanks for having me. I hope I didn't offend you.
Thanks for doing it, sir. Hopefully Josh will be ready to use the microscope when he gets to Charleston.
I think he will be.
Great talk. Appreciate it.
Bye. Take care.
Take
Thanks,
care,
everyone.
everyone.